look at the adductor canal block now. My preferred method is to start anterior on the leg and look for the femur, the bright white line at the bottom, and then start to scan medially. And what we're looking for is for the sartorius muscle. Now, sartorius comes into view, and I always describe it as being like the hull of a ship. We can see sartorius coming in there, and we can see those vessels below sartorius. Now, for the best block, we want to block within the femoral triangle, and that's described as the point that the abductor longus crosses the midpoint of sartorius. So I'm going to scan just a little bit more cephalad and put myself in this area so I can see from the left-hand side of the screen, which is the anterior side of the probe, vastus medialis. The sartorius muscle is superficial, and then adductor longus. And then we can see the artery in the vein sat below, nestled under the sartorius muscle. Now, this is a saphenous nerve block, and the saphenous nerve will sit on the anterior, occasionally over the posterior edge of the femoral artery. Now, the needle insertion point is going to be anterior, so from the top of the probe, coming in, through the fascial plane that borders sartorius and vastus medialis. Now, I would advise you use a nerve stimulator for this. The medial retinacular nerve can sometimes live within that space. It certainly travels within that fascia. So by using nerve stimulator, it gives us that extra safety net. We want to put our needle on the anterior side, so the left-hand side of the vessel. Aspirate very carefully, ensuring there's no small branches of that artery, and then inject slowly. And again, this is another block where the nerve will declare itself. A lower volume block, the more local anaesthesia you inject into the femoral triangle, the more probability that this has to spread up and give you a femoral nerve block. Now, we use this block, of course, a lot for total knee arthroplasty, and we really do not want the patient to have a femoral nerve block, as we will want them to ambulate and mobilise very quickly. So 10 to 15 mLs of local anaesthetic would be your maximum dose of local, watching that spread nicely. So again, anatomically, we have vastus medialis, sartorius, adductor longus, artery, vein, and the saphenous nerve.